the measurements. Okay, you're gonna have to guesstimate the measurements because it's a complex area, okay? Next, you're gonna do a sagittal, medial to lateral, or lateral to medial. This is on a cine, okay? Then you're gonna do transverse, superior to inferior, or inferior to superior, okay? And this is gonna be one shot, this is gonna be the other shot, and you're just gonna do a cine and then you're done, okay? That's the hardest thing to remember as a new sonographer, is because you want to find that ovary. You won't be able to see the ovary, okay? Just give it up, do a cine, and go to the next thing, okay? But you still have to do your superior, mid, with and without measurements, with and without color, and then your inferior, then your sagittal. And you can either start medial or lateral to medial. It doesn't matter, as long as you cut the organ the way that it should. Okay? Okay, everybody understands the grid. Okay? As long as you cover all of that, then you're okay. What was I doing? Yes. Oh, there it is. Okay. Tubal ovarian complex. I put it as P because you can see the ovary and the tube, but you do have adhesions because of the infection. It's not as bad as a TOA, but almost. Okay, so I put it as a P. Adenomyosis. Adenomyosis, I put it as A. Everybody else got that?
Yep.
Adenomyosis, there's two different things. You have endometriosis and you have adenomyosis. Adenomyosis. It's usually going to be the posterior body. So the posterior body will be bulky. Okay? So when you're looking at a sagittal uterus and you see myometrial cyst, that's adenomyosis. Adenomyosis. Okay? In other words, if you see a fibroid and you turn on it and it disappears, it's adenomyosis. Okay? Endometriosis. Okay? That's where you have a chocolate cyst. Okay? An endometrioma, or we call it a chocolate cyst. Okay? It's a homogeneous structure because of the blood in there. Okay? Yes. Yeah, you can come in. Oh, what? Uh-huh. Okay. 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 Sorry. Yeah, take it off. Okay. Now, this is something we haven't talked about. The fifth, you wanted to ask a question? Okay.
But the adenomyosis, it happens on the myometrium?
On the myometrium.
Not inside.
It says there that it's on the surface of, but it affects the myometrium.
And then the endo is in the
It's in the peritoneum.
the more outward.
in the adnexa. In the adnexa. Okay? So basically, endometrial cells that we slough off, they can regurgitate and go up the fallopian tube and get into my peritoneum. They can adhere to the surface of my uterus, and then every cycle they bleed. So it's very painful periods. Do what, honey? They think it's hereditary, but they don't really know that I know of. I'm sure they have, and I just haven't read it. But usually it runs in family members. Okay, but they say that once you get pregnant, it cures itself, but that's not true. Only because I have a cousin that had a daughter. She had endometriosis. Her daughter had endometriosis and had lots and lots of surgeries. And she had 3 children, but now her endometriosis is back because her youngest one is 4. So what's going to happen is those endometrial cells get attached to like your rectum, your bladder, and then they adhere to one another, okay, because of the blood. So it builds like adhesions up. But that's outside of the uterus, okay. Endometrial cells can also penetrate the myometrium. And if that happens, it's adenomyosis. Okay, adenomyosis. So those are the 2 differences between those. Fitzhugh-Curtis, we haven't discussed that any at all. Fitzhugh-Curtis, I put that as a G. That's where you have pelvic inflammatory disease, and it travels up towards the Morrison's pouch. And then you have infection that adheres the kidney to the liver, okay? And that's called Fitzhugh-Curtis. Dysmenorrhea, painful periods, I put that as a B. Salpingitis, inflammation of the fallopian tubes, I put that as N. Okay? Endometriosis. The cells have escaped the uterus, and now I have endometriosis outside of my uterus. We cannot make a diagnosis of endometriosis unless we see a chocolate cyst. That's the only way. I put that as D. Implants of endometrial tissue outside of the uterus. Myometritis, I put that as H, where you have myometrial inflammation. PID, I put that as K, because that's where you have infection of your female parts, okay? One of the ways that we make a diagnosis of PID is hydrosalpinx or pyosalpinx. That's how we make that diagnosis. Also, when we put the probe in, it is very painful. So dyspurenia, painful sex, and you will ask them, well, does sex hurt? And if they say no, continue your exam. Okay? If they say no, continue your exam. If they say yes, discontinue your exam. Yes.
There was a patient yesterday, it was transvaginal, and she was in pain.
Yes.
But the text, she keeps thinking like she was all the time, oh, I have a pain, but she doesn't have pain.
Yeah, that's up to the sonographer's call. Okay? If the patient tells you to stop, you have to stop. Okay? You have to stop. So that's a judgment call that only you can make as a sonographer. Okay? I usually say, if I put the transducer in and they go, ow, 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 that hurts, that hurts, that hurts. It's going, does sex hurt also? No. I'm going to finish my exam. Okay, because if sex doesn't hurt, I'm not going to hurt her. Because I'm holding the transducer like this. I'm not even pushing in. I'm guiding myself in. Okay? If it's going to hurt, my hand wouldn't be able to maneuver. Because I don't hold the transducer. I hold the transducer. Yes?
But she had an ovarian cyst and then she had fibroids. So that's not the cause of the pain? Those are not gonna be.
Nabothean cyst, no, unless they're just huge, large. Fibroids, I imagine fibroids do hurt, but I don't know for a fact,
And she was bleeding.
And it all depends on the tolerance of pain. Now, you can do an HCG and the woman never even, she'll say, we're done. Where you'll have the other ones go, ow, 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 I can't do this. No. Because I think it really just depends on how much you talk to your patient, how much you explain to your patient, and tell them. If it gets to the point where you want me to stop, all you have to do is tell me, and I'll stop. No, go. You want me to stop? No, go ahead. I need to find out what's going on.
Exactly what they said.
That's what they're gonna say. Okay, and finish your exam. I wouldn't try to go from one side to the other side, then back to that side, then back to that side. I'm gonna be very methodical about how I maneuver my transducer. Okay, I'm gonna be very conscious of what I'm doing. Dyspurenia, of course, that's painful intercourse. Endometriosis, I put that as F because it's the only one that said infection of the endometrium. Okay, endometrioma, I put that as E. It's a blood-filled cyst located on the ovary. We call that cyst a chocolate cyst. A chocolate cyst. Parametritis, I put that as J. No. I put that as, J. Infection of the connective tissue surrounding the uterus.
It's parasarel.
Okay. And 16, I put that as M, as peritonitis, and M says infection of the
peritoneum. Office.
Okay, so a lot of this information we've already discussed, so this should be a really, really easy chapter to read because we've already talked about everything.
Yeah.
Okay, the only thing that we didn't discuss was the Fitzhugh-Curtis. Fitzhugh-Curtis. Okay, yes.
Can we see that?
F. That's the F.
Sometimes you can. Sometimes you can't.
You got
But
one
the
wrong.
only way we can see adhesions is if they have fluid in the cul-de-sacs. Who's seen a lot of fluid in the anterior and the posterior cul-de-sacs? You can actually see everything.
Yeah.
You can see everything. Okay? Now, if I have a lot of fluid and I see like little flecks of blood in there, where it's not, the ascites is not anechoic, they call that malignant ascites. Okay? Because you've only got two things. Either you have a malignancy somewhere that's causing the ascites, or you're actively bleeding inside of the peritoneum. Okay? Yes.
Do you use saline to see additions?
To do what?
To see additions, do you use saline?
Saline.
Right?
Okay, so you have a catheter. That catheter is little bitty tiny. Okay, I would say it's about the size of the inside of a pencil. Okay, and it's hollow. It's got two attachments. One for saline for the balloon, one for saline that's gonna be injected into the uterus. Okay? The one that has saline has a balloon at the very tip of the catheter to keep it from coming out. Okay? So whenever they inject saline into, they pull back on that catheter to keep water from coming back out of the vagina. So it inflates the uterus, and so we can see the inside of the uterus.
Mr. Court,
Yes.
when they say vaginal bleed,